Hi guys. All right. So hi guys. All right. So I'm just going to jump right in, but first I need to give you my little disclaimer section. Anytime you see this little four peaks sign, um, just wanted to let you know that that means I have a little disclaimer. I know there's a couple of you pulmonologist types out there just chomping at the bit to comment on my work, and I just wanted to let you know that you got to pay attention to my disclaimer symbols first at the end of this video so that I can go ahead and jump right in to what I wanted to talk about. So here we go. I want you to understand that when we're dealing with pandemic ARDS and ventilators, that we are going to have 4 different types of objectives. And those are written right here. We're going to either rescue, stabilize, adjunct, or we're going to rest the patient, and we're going to wake up the patient after that if everything is stable here. And then if everything is stable after waking up the patient, we're going to work the patient out, and then we're going to set this patient up for success flying solo. I'm only going to talk about successful stuff today, all right? No failures whatsoever. We are going to succeed, even though we are going to spend most of our time here on a COVID patient. In the pandemic ARDS scenario, we're going to spend most of our time, maybe 2 to 3 weeks, in the resting mode before we wake up, and probably spend very little time, hopefully spend very little time in the pressure support mode without having to backtrack to any of the other ones. But those are fluid stuff, and that's why I have disclaimers everywhere. That's why it's littered here. I'm only going to talk about, for brevity and generality's sake, I'm going to only talk about what you see on the board. All right, so first, rescue, stabilize, adjunct. What I mean by that is we're going to use these. This is non-linear. This is kind of like a choose your own adventure kind of system. You might not need CPAP here. You might not need BiPAP here. You might just go from push port to nasal cannula. You might do a breathing treatment, and if that's successful, you don't need to do any of this. And so I'm just laying it out here so that I can explain ventilator settings and taking care of a ventilated patient. So anyway, this is your non-invasive ventilation here and here, and then these are your intubated patients. And so let's jump into our first acronym, PEEP. Peak and expiratory pressure. Peak and expiratory pressure. At the end of expiration, I have a expiratory pressure. And what that is, where'd I put it? An alveoli or glove. And as you can see, this alveoli or this glove is not fully deflated. It's not scrunched down. It has some air in it. The reason why that air is in it is because there is a column of atmosphere from here to the top of Mount Everest and a little bit higher, kind of like where the highest airplanes are flying, military airplanes are flying, maybe low-flying satellites are. There's an atmosphere that's pushing down on the inside of this glove, keeping this glove partially inflated. And that I can measure as about 3 to maybe 4 or almost 5 millimeters of mercury of pressure. Helium is lighter than air, and if I put helium and air in one spot, the helium will rise, the air will sink. Therefore, air is heavier than helium, and that pressure, that heaviness, is holding this alveoli or this glove open. If I put this glove inside my pocket, just the pocket alone or the inside of my lungs alone will add a little bit, 1 more millimeter mercury of pressure that I need to keep my alveoli open without being sick. That is PEEP. And you will see that on your ventilator settings, your PEEP at absolute best will always be a PEEP of 5. So you will never go down to a PEEP of 0. You will always go with a PEEP of 5. The reason is when I hook an ET tube to my alveoli and cut the ventilator off from outside intervention, I have a PEEP of 0, and that alveoli will begin to collapse pretty quickly. There's more pressure in the alveoli, and that alveoli will begin to collapse. So what I want to do is, as soon as I hook up that ventilator to that patient, to already have a PEEP of 5 dialed in. PEEP of 5. All right. So now I'm going to explain pressure support and BiPAP. The only difference between pressure support and BiPAP is in pressure support you're intubated, and BiPAP you're not intubated. But they both have an inspiratory pressure and an expiratory pressure. Technically in CPAP, technically in CPAP you only have a PEEP, an expiratory pressure. On BiPAP you have an inspiratory pressure and expiratory pressure. So let's go over that real quick. I am breathing through one nostril. Now, normal conditions, everything is hunky-dory. Breathing through one nostril is not an issue. However, if you collapse half of my lung, if you just finished doing open heart surgery, if you are just finished fixing my femur, it might not be so easy for me to breathe through one nostril. So, go with me for a second. Let's say I'm on a motorcycle. I like motorcycles. Let's say I'm on a motorcycle and I am going 5 miles an hour, PEEP. And I want to make it easier for me to breathe in on my motorcycle because I'm breathing through one nostril. I am going to throttle up to 20 miles per hour when I inhale. Whoa, that makes it so much easier. When I inhale, I throttle up to 20 miles per hour, and as importantly, when I exhale, I throttle back down to 5 miles per hour to make it easy for me to exhale. But don't go to 0 because then you'll get lopsided on your off balance on your motorcycle and you'll tip over. Just want to keep going at a constant 5 miles per hour, right? PEEP of 5, pressure support of 20. So 20 over 5 is how you're going to see a pressure support setting. All right, so pressure support setting 20 over 5. Now, I do have a little disclaimer at the end because you might extubate with a pressure support. And I'll give you a little bit more, again, disclaimer sign, a little bit more info at the end. I don't want to bog down my current lecture. Now we're going to concentrate on AC and IMB. And for our purposes, I'm not going to mention pressure AC or pressure IMV or PRVC, pressure regulated volume control. I'm not going to regulate that. There's several reasons why I'm going to talk about that at the end with my disclaimer series, but for my purposes, I'm only going to talk about volume AC, volume IMV. For this purpose, I'm going to set the same ventilator settings on both. Volume AC, I'm going to set a rate of 12 and a tidal volume of 500. And on volume IMV, I'm going to set a rate of 12, tidal volume of 500. Okay, so the major difference is this is a resting mode. My patient is probably sedated and paralyzed and is on vasoactive meds. And so I'm in total control of everything. I've guessed at his minute volume based on his height and ideal body weight. So it's based on his height. So his ideal body weight, I've calculated a tidal volume of 500. That's about 6 milliliters per kilogram tidal volume. So I'm going to calculate, you want to keep a low tidal volume, by the way, on COVID patients. Anyway, I've calculated a 500 cc tidal volume, a respiratory rate of 12. Every minute, both of these guys are going to get 12 breaths per minute, and they're going to get 500 cc breaths for those 12 breaths. In volume AC mode, on the 13th, maybe the 14th, 15th, and 16th, whatever he decides to take over the 12, he's going to get, the ventilator's going to finish it off at 500 cc's. So if he takes a 13th breath, he's going to get 500 cc's. If he takes a 14th breath, that 14th breath is going to be at 500 cc's. If he starts to take a 18th breath, that 18th breath is going to be a 500 cc breath. The ventilator finishes it off because I'm trying to rest him. I'm not trying to let him work. Now, when I'm starting to wake him up, I am going to give the exact same ventilators. He's going to be on an IMV, volume IMV of respiratory rate of 12, tidal volume of 500. When he takes that 13th breath, this guy is not going to get help from the ventilator. If he takes only a 50 cc breath, that 13th breath is going to be 50 cc's. In this case, he would have gotten a full 500. This case, he's going to get only whatever he decides to take. It's still going to, both these settings are still going to provide 12 breaths per minute, 500. This one's going to provide much more volume with every breath that he instigates over 12. This one is only going to get much less volume with any breath he instigates over 12. So the issue with that is you can over ventilate, over oxygenate this person. So this person can get, his minute volume will be high inadvertently because he's taking in bigger breaths than he actually needs. You're providing him more breaths, bigger breaths than he actually needs. So you'll either need to sedate, paralyze, add analgesics to this guy, or change his vent settings where he's not getting over the amount, especially if his ABGs are reflecting that he is getting over the amount that you want to give him, your goal, whatever your goals are. That might be your PF ratio. I'll tell you that in a second. When you're waking him up, you might not be ventilating him enough. He's taking guppy breaths. He's taking 200 cc breaths. He might actually need more than that based on his ABGs. You might need to change the rate. You might need to provide more PF2. You might need to wake him up more. He might just be too sleepy. So it might just be too early that you moved him to an IMV mode. So there's lots of different areas, but I want you to keep an eye on the big difference between volume AC and volume IMV. Volume AC, when he takes a 13th breath, that's going to get 500 cc's. When in volume IMV mode, when he takes a 13th breath here, he's only going to get whatever he decides he wants that day, and that might not be appropriate. He might be too sleepy for that. Okay, so those are your different modalities. Let's move on to what you're going to be monitoring. This is kind of the reason why I wanted to do this is because a lot of people are brand new and not used to taking care of all these ventilators all the time. So I want you to obviously we're going to talk about respiratory rate, heart rate, temperature, and SATs and or your SpO2 monitoring. I put a little asterisk here for your end-tidal CO2 monitoring because right now I know for that we don't end-tidal CO2 everybody on an event, but if you can, then monitoring someone's end-tidal CO2 is actually pretty high. That little number gives you a lot of information that actually supersedes some of these numbers. So you're, especially when you're dealing with someone who's awake. I also want you to be able to read ABGs. I think I have a little I think I have an episode out there about ABGs, and you're going to want to do ABGs after about 30 minutes after vent settings to figure out if you need to change anything. Super important. This is a perfect opportunity. I urge every single one of you guys, a perfect opportunity on downtime to ask your intensivist, ask your colleague that's more experienced than you what the chest x-ray shows. Pull that up on your patient, teaching, HIPAA violations, pull your chest x-ray up on your patient, try to find out where the carina is, try to find out where the atelectasis is, try to find out where the NG and OG tube are, where your landmarks are, see how to avoid not looking at the EKG leads and or become more cognizant of where your EKG leads are when you're doing a chest x-ray. so that you can see a proper chest x-ray. So anyway, let's go to back to AC mode. On AC mode, I want you to keep an eye on the peak inspiratory pressure, because remember, this guy is resting, and when his peak incentive, I want to say incentives for peak inspiratory pressures are rising, it's because he's waking up and he's taking deeper breaths. So he's going and if you wait until this thing is alarming, he might be fully awake. So if his pips are starting to rise and you notice that on the ventilator, then you have a head start on sedatives and analgesics and maybe paralytics that you need to do something before his pip alarms start to go. So you want to keep an eye on his pips. A little plus here for bonus points. I want you to look up plateau pressures, because if you understand what the difference is between an increasing pip and or an increasing plateau pressures, you have several actions to do. So I might, based on your comments and based on what you want, I might do a possible future episode on monitoring your patient, and that includes your PF ratio. But know your pips for your AC mode, know your spontaneous tidal volume for your IMV modes, because you could be providing too little of a minute volume or too high of a minute volume for these two guys, or actually in pressure support also. In your PEEP mode, I want you to be aware of your PEEP. That's super important. In our COVID patients, we're going to be providing high PEEPs. Normal PEEP's 5, that's our goal. We don't want to go below that. And then a moderate PEEP is like 8 or 10, and then a high PEEP is like 12. I've never seen anyone over 18. Usually by the time we're thinking about putting someone on a PEEP of 18, we've already got chest tubes in, because we know we're going to create pneumothorax. So normally PEEPs of 16, I am I'm very concerned about causing more barotrauma, more damage by high pressures. Again, low tidal volumes on these guys. Increase the heart rate, increase the FiO2, increase the PEEP. We're going to go with low tidal volumes on these guys. Some of them are super low. We're doing a little bit of studies. Some of the studies are actually lower than ideal tidal volumes. Keep an eye on your FiO2. Sometimes, a physician and or a colleague or RT will come in and change your FiO2. You don't know it, and you're doing all sorts of PF ratios on the wrong FiO2 level. So just keep an eye on your ventilator. Keep an eye on your numbers. Anyway, moving on. PAPR and isolation materials. I'm in my room, I'm gowned up, and everything, and then all of a sudden I hear my cuff leak going on. There's air coming out of this guy's oral airway. I have no idea, I need help, and there's 15 people outside of the room, but my isolation material, there's no PAPRs out there, there's nothing. And look, it's gonna take them 3 minutes, which means I'm flying solo for this guy for the next 3 minutes, trying to figure out what's going on with the alarming ventilator while I'm dealing with low blood pressure. Okay, so just make sure that's out there and or available. Just eyeball that. Same thing with your AmbuBag and BVM. Make sure there's one in the room. Yonker and suction. I can't tell you how many times I clean out the old suction container, and then I get called to a code, or I get called there, I get busy doing something, and then I totally screw the next shift by not giving them a suction catheter or Yonker. So when you get on board, take a look in the room without even all your stuff in. Make sure that you've got all this stuff in the room. Restraints also, I can't tell you how many times we intubate someone, we give them the drugs for pre-intubation, for intubation, and then they're not moving because of those, and then everyone forgets, we get busy, he gets sicker, and then next thing you know, he starts waking up, and the first thing he does is always pull out his ET tube, and I have no restraints anywhere. Or we need to deal with his ABG or his A-line, and we cut off the restraints or discombobulate, or tangle that up, and the next thing we know, patient starts to wake up and starts flailing around, or a shift later, we're waking him up and he starts flailing around, and I need to re-restrain him, and I don't have one in the room. Okay, NG and OG tube, they say about 25% of our ARDS patients also have aspiration pneumonia. That's a huge percentage. So especially at intubation time, you want to go ahead and have set up an NG and OG tube, throw that in, make sure you don't have any other issues going on, get a doctor's order. You don't want to have, for instance, a bypass surgery, a gastric bypass surgery or something that will prevent you from putting in an NG tube or OG tube. And then what you want to do is throw that in after intubation, after you secure the ET tube, get in the OG tube so that you can do a chest x-ray for both tubes. Make sure that both tubes are in place by that one same chest x-ray. So that's the reason why you want to get that on board soon after intubation. Keep an eye on that. Stethoscope and the 10 milliliter syringe. The 10 milliliter syringe is for the cuff. A lot of cuff issues go on if they deflate just because of where they are placed. Even if the ET tube just moves 1 centimeter, which might not do anything for him, it might even help him breathe, but that 1 centimeter movement can deflate your cuff, or that reposition can mess your cuff integrity, and so you will need a 10 cc syringe to add more or remove some air from that cuff. Know what a bougie is. I'm going to put a little disclaimer sign here. It'd be great if you knew where the bougie is and what it's used for. It's usually somewhere near your crash cart, but I know a lot of you guys may not know what a bougie is. Have that available on anyone who's ventilated. It doesn't matter if they're ARDS or pandemic, always have a bougie available whenever they're intubated. Know how to do an ABG. Also know how to set up an A-line. So another disclaimer, another additional point, bonus points for that, for knowing how to set up your A-line. Might do a possible future episode on that. Tube placement, always check your tube placement at the beginning of your shift, especially if you're pronating, repositioning, doing all sorts of stuff with your patient. Always know how many centimeters at the teeth or at the lips that tube placement in. I know some of you guys want to know the size too. I like to know what the size of the ET tube is, but we can pretty much eyeball the size of the ET tube in an emergency situation, especially if you're re-intubating someone. But I want to know how deep that tube should be, and then I want to check for bilateral breath sounds, especially on someone on high PEEP, PEEPs of 12, 14, 16. I want to be checking breath sounds every 2 hours, because the chances of pneumothorax and the chance of pulmonary effusion are pretty high on someone, especially on the extremes of elevated PEEPs that my ventilator settings are on. Also set up for the next shift, okay? I can't tell you how many times that you get on board and your drips are running low, and now you have to call pharmacy for them, and they're like, that's gonna take us like 15 minutes to set up. I hope you have that much. It's like, no, my tubings are sucking air right now. Get that going. Also know where your IV pumps are. Can't tell you how many times I've had everything set up to go, and then I go to the supply room and there's no IV pumps, and or I go to the clean supply room and there's no IV tubing. So make sure that you have IV pump, IV tubing readily available before you go into that patient's room. Same thing with your phone numbers. Know how to contact your RT. Know how to contact your charge nurse. Always keep them in the loop of what's going on with your patient, especially if your patient's in the extremes of your numbers here. So charge nurse, RT, always know how to get a hold of chest x-ray, to order that portable chest x-ray to get it done. You want to make friends with your x-ray tech, and you also want to know how to get a hold of your intensivist or your MD or whoever you need to call, in case the feces is hitting the oscillating turbine here. You want to be able to contact them and get to know them, and call them only for the important stuff. Right? If you start calling them for unimportant stuff, then you might be crying wolf, and then when you really, really need them, they're not coming. Same thing with your RN supervisor. There is one time I had to overhead page for something, and I thankfully notified the RN supervisor and told her that I was going to overhead page someone because I couldn't get a hold of the people that I needed to get a hold of. So again, follow your chain of command, notify your charge nurse, RN supervisor in case you need to overhead page because you couldn't get a hold of the intensivist or the MD that's on call. So just understand that you've got some help, but you got to ask for that help in a stepwise manner. Always start out with your RT and your charge nurse. Okay, now I am totally done with the part of the presentation that I want to do. I am going to add on to my disclaimer, so you can stop paying attention at this point. Here's my disclaimer, and you can start commenting or doing whatever you need to do now. Here's my disclaimer. No good deed goes unpunished. Always follow your protocols, policies, procedures. If you have an issue with your policies, protocols, and procedures, change them and then follow through with the new policies and procedures that you help change. All right? Never get in a situation where you're telling someone you did something because you saw some guy explain it on YouTube that this is the way it's supposed to be. All right? So be open for change. It is now April, May 2020. Tomorrow they can invent some kind of nebulizer that miraculously increases your heart rate, increases your blood pressure, and removes any ARDS from you, and you don't even have to intubate. This all becomes superfluous because something changed in the way. So I'm giving this as a disclaimer because what I'm saying right now is specific to this time and date. Things change depending on what new ventilator that they're going to create or what new drug or modality or situation that happens tomorrow. So be open for change. We got to evolve or we go extinct, right? So evolve with the times, guys. There's specialists and specialties out there that I'm not going to argue with. I'm just not. I know a Dr. R who's been a cardiothoracic surgeon for probably 40 years, actively at the bedside, and he and Dr. H works at a different hospital. He was a cardiologist for decades, then he became a CT surgeon for decades, and then he became a trauma surgeon for decades. He eyeballs someone and he tells the anesthesiologist in the operating room what vent settings he wants. Sometimes it's a pressure IMV. None of this stuff argues with that person, okay? There's some specialists that only deal with neonates. There's some specialists that only deal with broken femurs on 18-year-olds. This stuff is not for that. I'm not going to argue with that kind of patient population or that kind of specialist or specialty. All right, if I have any additional comments or if I have made any errors, I am going to put that in my comments section in wherever you find this video. So look in the comment sections for any additional stuff or any errors. I will have possible future episodes kind of based on if I fall flat on my face with this example, or if you guys like it or don't like it. I might proceed with possible future episodes based on where you see all the disclaimers and where I should explain more things like PF ratio and plateau pressure. All right, so in going back to my CPAP pressure support example, what I wanted to impart from you is let's pretend, I know it's a stretch, but let's pretend I'm 6'4" tall, 6'4" tall. I know it's a stretch. Let's say I'm 6'4" and I'm breathing through an ET tube that's a size 6. And those of you who are experienced know that that ET tube is way too small for that guy that's 6 foot something. He's got huge lungs, so he's having a hard time breathing. So his pressure support is dialed way high because I want him to get pressure support on inspiration to counterbalance that ET tube. I might extubate him if he's successful, even if he has a high pressure support. Let's say, and this is just an example, let's say his pressure support is 28. And his PEEP of 5, pressure support 28/5. and he's breathing through I'm 6'4" and I'm breathing through a 6.0 ET tube. If I might be able to extubate him on a 28/5. I wouldn't normally do that on someone with an appropriate ET tube, but the small ET tube size, the pressure support is to counterbalance the ET tube diameter, the inner diameter of the ET tube, not my lungs or my airway. So I extubate this guy with a 28/5 and he's fine. He could probably go on nasal cannula room air. The high pressure support was because of the ET tube diameter. Okay, that's one thing I did want to impart with you. The other thing, the last few things, is the upcoming, hopefully in a couple of months, I'm going to put all of my videos in different forums all across the internet. I've kind of been doing this for a while. I'm going to put that all on my new, hopefully new website, and it's going to be outsidej3.com. And I've done this all in one take. It's super hard for me to get this all done. I would love to hire some people who know what they're doing with the editing. I'm doing this off my spare phone. So if you want to help me out with that, then here's my Venmo, Outside J. If you want thanks on that, I will certainly add you on to future videos if I do them. For any donations I get for these educational videos that I hope will continue to be free, because I have no reason to try to make any money off of it. It's just that right now I do need to hire an editor. So cheers. I am going to duck out of here, and I'm going to leave this up so that you can do a screen grab for it. Thank you very much, and then feel free to rewind and check out anything. Feel free to comment on anything that I missed, and I will either add that on somehow or redo this video or do something else or make future videos. Cheers and mahalo, and another time.